Welcome to part 3 of the neuromuscular basis of movement. We are going to, in this segment, be looking at the structure and function of the motor unit and also the structure and function of receptors. We're going to start with the motor unit, and you have seen this before. We looked at this when we looked at the muscular system. A motor unit is really the combined function of two cells, a neuron and a set of muscle fibers or muscle cells. So we have one motor neuron and all the muscle fibers or muscle cells that it innervates. Remember when we talked about spinal nerves, so this should look very familiar to you. Here's the cross section of the spinal cord. You should not be surprised to see that the cell bodies of these motor neurons are in the anterior horn. What's this round bubbly thing here? Yep, if you said the dorsal root ganglion, which I'm sure you did, you're correct. And that's going to carry only sensory information into the dorsal horn of the spinal cord. So the cell bodies of the motor nerves are in the ventral or anterior horn of the spinal cord. So this red one and this blue one represent one of many, many axons or neurons coming out of there. And of course, remember here, this is the spinal nerve where motor and sensory information is both carried. We're focusing right now on a motor unit, so we are only interested in the motor neurons. So the motor neurons are coming out of the spinal cord. There are two axons portrayed here. This red one is coming down, and I guess I'm starting with motor neuron number 2, and it is innervating 1, 2, 3, 4 muscle fibers, and then motor neuron 1, the blue one, is coming out and also innervating 4 muscle fibers. And again, this is what we would call the functional unit of the neuromuscular system. So our goal again is to understand how movement occurs and how it's produced, and this is a functional motor unit. In the previous video we looked at how action potentials are created and saw how the impulse, so you can imagine action potentials traveling down these axons. We looked at a synapse before, so that impulse would synapse or travel from the motor neuron onto the muscle. We talked about how muscle contraction occurs in the muscular unit. So now we're really just putting it all together and looking at how everything together. How does a muscle move or contract? We spoke before about there's a variety of sizes of motor units. So each of these two happen to be equal, but if you think about your hands, the motor units in your hands and finger muscles are very small, and that gives you a lot of precision of movement. If you think about the motor units that go to the muscles, say, of your back or your quadriceps, there are going to be many, many more muscle fibers per each axon, which is not going to give you as much precision, but will give you potentially more force when each one contracts. When we think about how motor units are recruited, that's the term we use for when each specific motor unit gets turned on or activated. So again, once an impulse starts going down that motor axon, all the muscle fibers that it's attached to are going to all contract. So our body wants to be efficient, and so when your brain tells your arm or your leg to do something, it starts sending out action potentials along these motor neurons, and it's going to recruit the smaller motor units first, fewer fibers, because that's more efficient. Why would you recruit a big motor unit with lots of fibers and lots of force if you aren't going to need all that? So we start first with the smaller ones, and here's our little graph. We have muscle force or muscle tension on the vertical axis. On the horizontal axis is time. And so if we find we haven't adequately created enough force, then we can recruit another motor unit. That'll be a little bit bigger one. That'll give us more force. And if we need a really large one, lots of force, we can recruit bigger motor units, and that will give us a lot of force. Now again, this happens very, very quickly, but your body is going to be efficient, and it wants to start recruiting and just kind of slowly build up until you have just enough force recruited, but not too much. And then as we relax, we reverse that process. The bigger motor units relax first, and then the medium, and then down to the smaller motor units. This is another way to look at force production, and you want to be correlating this with the information we talked about earlier with the muscle unit about how muscle force is regulated and produced. So if we have the same motor unit being recruited but not very frequently, we're going to generate about 2 grams of force. A little bit more rapid or frequent recruitment will increase our force, and again, if we can recruit that same motor unit very, very often, we're going to build that force. And so the fewer or the more time in between, we give the muscle a lot more time for relaxation, and the more rapidly we recruit it, we don't allow as much relaxation, and so we are able to build a greater peak force. So ultimately, when we're looking at the amount of muscle tension we can generate, it really comes down to 3 elements related to motor units. 1, how big is the motor unit that we're recruiting? A larger motor unit is going to have more muscle fibers, which is going to have more sarcomeres, so that's going to generate more force. The number of motor units activated, I didn't really talk about that, but if we have several motor units, we're going to have a lot more muscle fibers, and that's going to generate more force. And then this slide illustrating the more frequently each motor unit is firing or recruited, the more force we're going to create. Okay, so motor units tend to confuse people. I'll be happy to answer questions, or we can continue to go over this, but it is very important for you to understand the elements of motor units that contribute to force production. Size of the motor unit, the number activated, and the frequency of firing. Alright, we're going to switch gears and go on and talk about receptors. So we're almost to the end of putting this whole big picture together. We just talked about motor units, which is kind of the delivery point for motor impulses. I want to talk about receptors because that's the starting point for sensory information coming into the body. So we've already looked at how that sensory nerve travels up, goes into the dorsal horn of the spinal cord, and now what I want to look at is how do we actually start that impulse. What you see here, of course, is a segment of the dermis, and these are little hairs in your skin. So here's your epidermis, the top light pink color, and then here's your dermis, this whole big thing. And within your dermis are many, many structures like hair follicles, and you can see here there's this little black thin strand. This is a nerve winding around the muscle at the base of each hair follicle. We talked about this in patient interventions, that when you're cold, this muscle contracts and does piloerection, or elevation of the hair follicle, to trap, in an attempt to trap air against the skin, but mostly what you see is just goosebumps. So there's that nerve illustrated there. So like this little green thing here and this little blue thing here, these are sensory receptors. Other things in the dermis that you can see illustrated, this little white, kind of off-white squiggly thing is a sebaceous gland, so that produces oil to keep the skin supple. And of course, capillaries, blood supply. And then these little black things and these little blue things, these are all different types of sensory receptors that we have in our skin. I am not going to quiz you on this, and I know this is a really small print, busy slide, but it gives you a sense of many different types of sensory receptors that we have in our skin and mucous membranes. So we've got unencapsulated and we've got encapsulated. They have really cool names like Merkel's discs and Meissner's corpuscles and Ruffini endings, all kinds of stuff like that. You again aren't going to be responsible for most of those either, nor do I care if you know their body location or their stimulus. But in general, I want you to understand that we have some big divisions. We have sensory receptors that are in our skin and our mucous membranes. Those are called exteroceptors. And then we have other receptors that are located in muscles, tendons, joint capsule, and ligaments, and those are proprioceptors. So we're going to be talking about those two kind of separately. But this gives an idea that there are many, many different types of sensory receptors because each one does a little bit of a different task. So some sensory receptors that we have in our skin are going to give us information about temperature, and some will give us information about pain. Some will give us information about touch, just general touch. Some will give us information about deep pressure or vibration. There are proprioceptors in our skin, and I'll talk more about those in a little bit. And then there's some receptors that are sensitive to what we call two-point discrimination. And I want to explain that one because that's probably not as familiar to you. And what you're seeing here in this item is kind of like something that looks a little bit like a compass, you know, like what you would have had in math class to make little arcs or something. And at the end of each point here is a little sharp point. And so what they're doing here is measuring how far apart the points of the compass are when they're touching them on the skin. And what that helps us to appreciate is how big the receptive field is, or how much area is each receptor covering in the skin. So if you take somewhere that's very sensitive, like the tip of your finger, part of the reason we say it's sensitive is because there are lots of sensory receptors. So it's kind of crammed full of sensory receptors. And so when you have the compass a certain distance apart, one prong is going to touch the sensory field of one receptor, and the other prong is going to touch the sensory field of a different receptor, and it's going to feel like two different touches to you. By contrast, we could keep that compass the same distance apart and touch it somewhere very less sensitive like the back, and you have one big receptor that's covering that whole area. So if you touch it, even if you touch that same receptor with more than one prong, it's going to feel like one sensory input. So this is a lot of explanation. Again, we're not really going to use this in this course because this doesn't give us a lot of information about how to control normal movement. But sensation in general is very important to normal motion, because if you've ever had your fingers go numb or your foot fall asleep, you know how clumsy your movement can be after that. And so I just want you to understand the concept of sensation, how it gets into the body, and then ultimately we will be looking at how it helps to control normal movement. But I wanted to explain two-point discrimination because it is one of the functions of the exteroceptors, and again, it's not something you probably would have come in contact with before. Another thing that's important to talk about in relationship to sensation and movement is reflex movement. Our focus in this class is going to be on voluntary movement, but there are some movements that are reflex in nature. In other words, we don't really control them. They happen because we've gotten a certain type of sensory input, and so we automatically get a motor output. And an easy example of this is if you've ever touched your finger into the palm of an infant, what does that infant do? Right, they grasp your finger. And while we would like to think it's because they love you so much, it really is a stimulus response or a reflex event. So the stimulus was the light touch to the palm, and the response is the grasp of the fingers. So for reflex motion, you have to have sensory input in order to get a motor output. That is not the case with voluntary motion, thank goodness. If you go to stand up or you go to type on the keyboard, you can type or stand up and walk around, not because you got a sensory input first, but you can just generate that motor output. That's voluntary movement. We do, though, need to understand reflex movement, again, for looking at pathologies and understanding a lot of the things that you'll be talking about in your neuro course. So here's another example of a reflex, and this reflex is called the Flexor withdrawal reflex. And let's take a look here. So here's our by now very loved, much loved cross-section of the spinal cord. Here's our dorsal horn, or dorsal root ganglion with our cell bodies of our sensory nerves coming into the dorsal horn. So by now, anytime you think dorsal horn or dorsal part of the spinal cord, you should think sensory input. When you see ventral or anterior horn of the spinal cord, you should think motor output. So let's see, way down here, number 1, stepping on a glass is a painful stimulus. So that's the painful stimulus. So that painful stimulus travels up through the dorsal root ganglion into the dorsal horn. It synapses immediately onto the axons in the ventral horn, the motor neurons that come right back down and make the flexor muscles contract in the leg. There's no sending information up to the brain. We don't wait and say, oh, I think I'm stepping on a piece of glass. I should probably pick up my foot. It's a reflex. It happens very, very quickly. And again, it's just sensory input, motor output. And lucky for us it does, because that's a very protective element for us. And so this is a reflex that we do see a lot of reflexes in babies that go away. This is a reflex that doesn't go away, and this is one that, again, is very helpful and productive for us as adults. So again, for every reflex, you need to know the stimulus and then the response or the motor output. So the stimulus for the flexor withdrawal is painful stimulus of the extremity. The response, contraction of flexor muscles of that extremity. You could do the same thing in the upper extremity. Let's say you went to touch something hot. What does your hand do? Right, it pulls away. So you contract the muscles in the flexor muscles in that upper extremity, sometimes before you even realize you've touched something hot, or you certainly before you think about it. So again, it's a good reflex, good protection. Now, on the other side, they're illustrating a different reflex. The reflex here is the crossed extension, or the extensor thrust reflex. Sorry, extensor thrust. So the stimulus here is pressure on the ball of the foot, and the response then is contraction. So that stimulus would go up, and then the contraction would be contraction of the extensor muscles of the leg. Now this illustration confuses people a little bit. I'd like you to go more by what I have in the lecture notes. So think again about an infant. If you stand an infant on your lap, even a very young infant of just a couple of months, they'll kind of lock their legs and stand on your lap as long as you're supporting their trunk. Again, is it because they're so wonderful and smart and strong? Sure. It's also because you've given them sensory input into the plantar aspect of their foot, and the response, the motor output, is contraction of the general extensor muscles in the legs, which locks their knees and kind of puts them in tippy toe and has them stand in your lap. All right, and then I've already gone through the palmar grasp of the reflex in the infant. So again, sensory input is touching the palm of the hand. The motor response is grasp of the fingers. So this is reflex movement. Again, it's important to understand how that's created. It's different than voluntary movement. It's also a great way to review the anatomy of the interaction between the peripheral axons and spinal nerves and coming in and out of the spinal cord level. All right. So let's go on now to proprioceptors. And what I want you to focus on is in the bottom right-hand corner of this slide, 2 proprioceptors, which are the muscle spindle and the Golgi tendon organ. And those are going to be the 2 proprioceptors we're focusing on right now. But I'll tell you again that we have proprioceptors, and P for position. So proprioceptors help us know where our body is in space. We also have them in joint capsule and ligaments and in our skin, and they tell us where our body is in space without us having to think about it. And an easy way to think about having proprioceptors in your skin is if you just make a fist, look at how the skin is stretched over the knuckles of your hand. So there are proprioceptors that are responsive to that level of stretch, and so when that skin gets stretched, they are sending signals up to your brain saying, hey, your MCP joints are in full flexion. Okay, and your brain's interpreting that. So that's a little bit about how proprioceptors in your skin could work. But again, I want to focus right now on 2 major proprioceptors, the muscle spindle and the Golgi tendon organ. So we'll start with the Golgi tendon organ. Golgi is just somebody's name. Tendon, of course, it's in tendon, and organ just means it's an organ of reception, so it's a proprioceptor. And we find this in what we call the musculo-tendinous junction. So the junction where tendon is blending in the muscle, or muscle's blending into tendon before it attaches to the bone. So these are all illustrating. There's little receptors right at this junction. And then, of course, those receptors have to have axons because they're going to send information to the spinal cord and ultimately up to different levels of your brain. So the stimulus that activates this receptor is high levels of stretch and also a very low level of active muscle contraction. So we activate or start sending action potentials along these receptors when we have a lot of stretch, and we can add a little bit of low level of muscle contraction. So if we have a stimulus, then again we can look at a response, and the response is to allow the muscle in which the Golgi tendon organ, often referred to as the GTO, we allow that muscle to relax. So if we stimulate the GTO, the muscle in which it's located will relax a little bit. This is very useful when we're stretching people. And you've probably had the experience where you've held a stretch for a period of time and you kind of feel a little bit more give. And that's essentially the Golgi tendon organ response kicking in. You've stimulated the GTO with that high level of stretch and by holding it, and then and it does have to be a prolonged stretch, and then the response is the muscles relax a little bit and you feel that little bit of give. And so physiologically, we feel like this is probably originally designed to help protect muscles from overstretch, from tearing. So if we can have a little bit of a give at the end of that range, it'll prevent like a muscle strain or tendon strain or rupture. Again, physiologically, or therapeutically, we use it in stretching to gain a little bit more range of motion. And this is noted as your tendon reflex. There's another reflex called the clasp knife reflex, and if any of you have ever had a knife that it kind of snaps open like a pocket knife, and then when you go to shut it, you get a lot of resistance, so you try to, because the knife wants to stay open, but then you push it to a certain level and then snap, all of a sudden it closes on you. They always make me nervous because I always feel like I'm going to cut my finger off. But that's where this term comes from, clasp knife reflex. This is a reflex or a response to stretching that we see only in people who have damage to the brain or spinal cord. So what would an example of damage to the brain or spinal cord be? Yeah, spinal cord injury, traumatic brain injury, a stroke, CVA, those are things that damage the brain and spinal cord. Those people can have spasticity, and we talked about spasticity before. That is a condition where the muscle contracts because of this damage to the central nervous system. So one way we can try to stretch out these spastic muscles is to apply stretch, and this time when we do this prolonged stretch, what we see is not just the little bit of give that you might have experienced when you've stretched, but a very dramatic giving away of the spasticity. It just melts away and releases, and you can get a lot of range of motion. So we take advantage of the Golgi tendon organ, the tendon reflex, with people who don't have damage, just to try to increase flexibility. And we take advantage of it with people who do have central nervous system damage to try to diminish spasticity and help retain and restore range of motion in those patients. So that's the Golgi tendon organ. The other proprioceptor I want to talk about is the muscle spindle. And so basically we have a little muscle here attached to the femur, and the term muscle spindle just came in because early anatomists thought that these receptors were spindle shaped. So they're little spindle shaped receptors, and they lie in parallel, so they're snuggled right among the muscle fibers. And so that's what you're seeing here, this little insert here. And so that's the receptor, and again it has axons coming out of it going to the spinal cord and other places, eventually up to your brain. And this also gives your brain information about where your body is in space. Now this receptor responds to low levels of stretch but applied very quickly. So quickly that, and such a low level that you might not even traditionally think of it as a stretch. And you might think of it more as a tap. So for example, when we have a tap on a tendon, like when we're checking reflexes, that counts as a low force, very quick stretch. So if you follow, again, the diagram, so here's our muscle, our quadriceps muscle. Here's the muscle spindle, that receptor kind of lying in and amongst the muscle fibers. It is stimulated with this little brief, quick stretch. It sends the sensory information up through the dorsal horn. Then it synapses immediately right on the muscles, comes back and causes that muscle in which it's located to contract. So this is kind of the opposite of Golgi tendon organ. Golgi tendon organ caused the muscle in which it was located to relax. The muscle spindle stimulus causes the muscle in which it's located to contract. So that's why when you have a little tendon tap, you get a little kick of the leg. Okay, it's a stimulus response. Again, it's not voluntary movement. And again, in normal function, we can look at the levels of this response to see if there is damage. If someone does have damage to the central nervous system, this response will be greatly exaggerated. If somebody has damage to the peripheral nervous system, it'll be greatly dampened. But in general, again, stimulation of both the Golgi tendon organ and the muscle spindle gives us just kind of constant information about the tension and the position of the muscles in our body. And you probably have never been aware of this because it's unconscious, it's subconscious information. But without these, we would have a much greater difficulty coordinating our movement, knowing where we are in space. All right, as I mentioned, we also have receptors within our joints, and again, can tell us what the difference in angle is in our body segments and our position without having to look at our body. So that saves us a lot of time and helps us be smooth and fast and coordinated. Another example of a proprioceptor you might not even think about is really in your inner ear, and this is in your labyrinth. So the labyrinths are basically fluid-filled cavities, not in the middle ear but in the inner ear, and they are these labyrinths are basically oriented with our cardinal planes. So you have one in your sagittal plane, one in your horizontal plane, and one in the frontal plane. And so as you move your head in different positions, it causes fluid to flow through these canals. And here's another little inset. The fluid flow in the canals stimulates these little cilia, or little hairs, and the movement of those little cilia send impulses down through sensory nerves. So basically, as you move your head around, fluid flows in different canals and at different speeds, stimulates that, and that tells you where your head is in space. This is very closely aligned or oriented with the proprioceptors in your neck, which, of course, the joints also tell you where your head is in space. This is also closely oriented with your visual system. So if the input coming in from your vestibular system, your eyes, your visual system, and your neck proprioceptors and your other body proprioceptors aren't all sending the same information to your brain, you're going to be dizzy and feel sick. And so for many of us, as we age, we do have changes or a little bit of a slowdown in the vestibular system sending information. And so, that tilt-a-whirl that you used to enjoy when you were 10 or 12 or 14, you might not enjoy it so much now, or the zipper or some of those other crazy rides. So there are changes in the flow of fluid through the vestibular system, and it can make you motion sick or car sick or sick on rides or something like that. So this is just, again, another example But the labyrinths are very, very important for letting us know when we're upright and what our orientation is to gravity in space. So when we see patients who have impaired vestibular dysfunction, or they have vestibular dysfunction, they have a lot of trouble with balance and a lot of dizziness. So again, it's a proprioceptor because it helps us know where we are in space and it helps us know our position. All right, that's really about it for this segment. And again, looking at a lot of different elements, this time on the sensory side of the nervous system for this last part, to help us see how sensory information coming into our body is very important for us to be able to control the motor output that we send out of our body. Okay, that's the end of part 3. You just have one more part coming up, and then you'll be all done with the neuromuscular basis of movement. Thanks a lot.